Every day, your kidneys filter your entire blood volume multiple times. They act as a sophisticated regulatory system, actively balancing essential minerals like potassium and sodium while pulling excess water out of circulation. When those organs fail, losing 85 to 90% of their functional capacity, toxic metabolic waste products like urea and creatinine back up into the bloodstream. This accumulation creates an immediate physiological crisis. Without filtration, excess fluid physically overloads the cardiovascular system, and surging potassium levels threaten to fatally disrupt the heart's electrical signals. To survive, the body requires renal replacement therapy, a mechanical intervention that takes over the regulatory duties of the failing organs. This chart tracks the estimated glomerular filtration rate, or eGFR, which measures exactly how well the kidneys clean the blood. The medical necessity for mechanical intervention arrives right here, at stage 5, when the eGFR drops below 15 milliliters per minute. Patients reach this exact threshold in one of two ways, either through the slow, multi-year decline of end-stage renal disease, or from acute kidney injury, where physical trauma or toxic drugs cause the organs to shut down within hours. At this precise numerical threshold, conservative pharmacological management reaches its limit. Connecting the patient to an advanced artificial filtration system becomes a direct, urgent matter of life and death. Once intervention is required, the patient and care team select between two distinct mechanical pathways: hemodialysis and peritoneal dialysis. Hemodialysis routes the patient's blood outside the body, running it through an external machine, or artificial kidney. This is typically performed in a clinical facility 3 days a week for 3 to 4 hours per session. To handle that kind of rapid blood flow, surgeons must prepare an access site months in advance. They connect a natural artery to a vein, creating an arteriovenous fistula that thickens and matures over time, or they implant a synthetic graft. Peritoneal dialysis, conversely, uses the patient's own body as the filter. Through a permanent abdominal catheter, sterile fluid is introduced into the peritoneal cavity, absorbing waste across the natural lining of the abdomen. It requires no needles and is usually performed daily at home, sometimes while the patient sleeps. Both modalities effectively cleanse the blood, yet this choice between external machinery and internal biology dictates how a patient will structure their life, their mobility, and their independence. Inside an external dialyzer, thousands of microscopic synthetic fibers act as a semi-permeable membrane. The patient's blood flows through these porous fibers in one direction, while a specially formulated cleansing fluid, the dialysate, flows the opposite way. This creates diffusion. Small waste products like urea are pulled across the membrane into the cleansing fluid, while essential blood cells and larger proteins are left safely behind. To manage fluid balance, the machine uses ultrafiltration. By establishing precise pressure gradients, it physically forces excess water out of the bloodstream and into the discard pile. Pulling that volume of fluid from the body in just a few hours creates immense physiological stress. Patients frequently experience sudden drops in blood pressure, dizziness, and painful muscle cramps as their vascular system struggles to compensate for the rapid volume loss. When engineers and doctors first developed these large rotating drum dialysizers in the mid-20th century, they took a universally fatal diagnosis and made survival possible. Yet, while the physics are brilliantly effective, the process is aggressive, routinely leaving patients with a deep, lingering exhaustion known as the dialysis hangover. Because in-center hemodialysis only cleans the blood a few times a week, patients must adopt a highly restrictive renal diet to prevent toxic elements from silently building up between treatments. Potassium regulation requires absolute vigilance. A spike in potassium from eating a banana or tomato can interfere with the electrical impulses of the heart, leading directly to cardiac arrest. Phosphorus management is equally critical. Failing kidneys cannot clear it, and high levels in the blood will actively pull calcium from the skeleton, leaving bones brittle and causing severe, relentless skin itching. This creates a challenging dietary paradox. Patients have to strictly limit their fluids, sodium, and essential minerals, yet they must significantly increase their intake of high-quality protein to replace the nutrients lost during the dialysis process itself. The machine manages the biological baseline, but it is the patient's daily nutritional discipline that dictates their safety, comfort, and longevity. The burden of chronic kidney failure extends well beyond the body. The intense physical changes and logistical demands result in approximately 50% of dialysis patients experiencing clinical depression or anxiety. To navigate this, the care team includes a renal social worker. They step in to untangle the administrative complexities of Medicare, coordinate financial aid, and fiercely advocate for the patient's employment rights. The treatment schedule also forces a heavy restructuring of family dynamics, often requiring spouses and children to take on demanding, unpaid roles as full-time caregivers. All of these sacrifices serve a singular purpose. For the vast majority of patients, chronic dialysis is not the permanent goal. It is a biological holding pattern, keeping the body viable while they wait on the national kidney transplant list. By adhering to strict dietary guidelines, protecting their surgical access, and leaning on their support network, patients can maintain a fulfilling life while they wait. Dialysis is demanding, exhausting, and complex, but ultimately it is a life-sustaining bridge that connects a failing organ to the very real possibility of a completely restored future.